Good afternoon, medical professionals and the general public. My name is Bridget Collins, and I am the co-chair of MEAction Maryland. And welcome to our first presentation in the series of evidence-based pediatric MECFS webinars with Dr. Peter Rowe. Cases of MECFS are rising across the country. Our concern is with a forgotten demographic, pediatrics. The goals for today are to 1, learn evidence-based options for treating MECFS. 2, understand the Institute of Medicine, IOM, diagnostic criteria and evidence-based criteria. 3, understand clinical presentation, epidemiology, and impact of pediatric MECFS. And 4, understand the history and stigma surrounding ME based on older views and pathophysiology. MEAction Maryland is a peer support organization for complex chronic illnesses founded in 2020 by 2 people with ME, Belinda Lipscomb and Whitney Fox, both of whom are unable to be here today due to severe illness. For the past 4 years, we have provided community support to people with complex chronic illnesses across the US and Canada. We also inform government agencies and officials. Medical education is very important to our chapter. This event forms a piece of our series of medical education for pediatric MECFS that we will facilitate throughout the rest of this year.
My name is Gwen Dujardin, and I've been doing medical and community education with MEAction Maryland for the past 3 years. I'm happy to be here to tell you what you can expect today and in the months to follow with this webinar series with Dr. Rowe. Today, Dr. Rowe will be presenting on evidence-based pediatric MECFS, an introductory overview. Following his pre-recorded presentation, I will lead a discussion with individuals and caregivers with lived experience of pediatric ME. Please be sure to put in your calendars that our next presentation is scheduled for August 12th, 2024 at 1 p.m. on orthostatic intolerance in the pediatric population. Potential topics for future webinars include other areas of Dr. Rowe's specialization, such as joint hypermobility, allergic inflammation, and biomechanical strain. Our final webinar, forecast for December, will include a panel roundup responding to all the audience questions from the previous webinars. We are eager to hear from you and answer your questions. Because our presentations are pre-recorded, we cannot respond to your questions live. However, we ask that you please email your questions for Dr. Rowe and our lived experience panelists at meactmaryland@gmail.com. Let's get started with the main event.
Dr. Rowe is a professor of pediatrics in the Division of Adolescent and Young Medicine at Johns Hopkins University School of Medicine. He's a graduate of Trinity College, University of Toronto, and the McMaster University School of Medicine, Canada. He completed his residency, his fellowship, and chief residency in pediatric at Johns Hopkins University Hospital. Dr. Rowe's clinical and research interests for the last 30 years have focused on medical conditions characterized by the symptom chronic fatigue. His work has emphasized the importance of a variety of physiologic risk factors for MECFS, including orthostatic intolerance, joint hypermobility, allergic inflammation, and adverse biomechanical strain. He has directed the Chronic Fatigue Clinic at the Johns Hopkins Children's Center since 1996, where he is the inaugural recipient of the Sunshine Natural Wellbeing Foundation Chair in Chronic Fatigue and Related Disorders. Dr. Rowe was a member of the Institute of Medicine Committee on the diagnostic criteria for myalgic encephalomyelitis chronic fatigue syndrome. And I promise you that all the above introduction was indeed the nutshell version. Thank you, Dr. Rowe.
Well, thank you, Bridget, for that introduction. It's a pleasure to be with everyone today. I'll be presenting a talk on evidence-based pediatric MECFS that is drawn from our last 30 years of experience working on this problem at the Johns Hopkins Hospital. I don't have anything to disclose. What I want to do in this talk is describe some of the older and now completely obsolete views about the pathophysiology of ME/CFS, because sometimes these views persist. And then I want to move on to describe the Institute of Medicine criteria for the diagnosis and then the evidence that is behind these criteria. I also want to talk about the clinical presentation, epidemiology, and impact of this illness in pediatrics, and then give people a sense of the clinical evaluation and evidence-based options for treatment. So that's the overview. Let's begin with some of the obsolete views of the pathophysiology of the illness. In earlier times, because the illness disproportionately affects females, and the older data suggested that there was an upper middle class socioeconomic status predominance, and people had multiple symptoms, many had been taught in medical school that that was all associated with a psychosomatic origin of symptoms, especially the multitude of symptoms in different systems. And at the time, the physical examination and the laboratory tests were said to be completely normal, and that fit with some kind of psychosomatic theory. So then from that came the understanding or the hypothesis that the illness stems from abnormal cognitions or thoughts about symptoms, and therefore should be amenable to cognitive behavioral therapy. So the next couple of slides show you a little bit about that. This was from a book called From Paralysis to Fatigue by a medical historian on a history of psychosomatic illness in the modern era. And he wrote that our culture witnesses a kind of collective hypervigilance about the body and a readiness of a large number of people to cling tenaciously to a given diagnosis, by which he meant CFS, as the illness was called at that time, refusing to abandon their belief despite medical reassurance to the contrary. So the poor patient who felt unwell on a physical basis and stated so was said to be protesting too much about their supposedly artifactual illness. This kind of paper emerged that there was a very low yield of physical examinations and laboratory investigations of people. They termed it with chronic fatigue, but they also inferred that this was the case for chronic fatigue syndrome. And then in 2011, the Lancet published the PACE trial. So the PACE trial suggested that cognitive behavioral therapy was really the most effective treatment for ME/CFS. But I want people to notice on the x-axis, they've manipulated the scale. So this is on a Chalder fatigue score that's a 33-point fatigue scale. Even the so-called best therapy led to about a 2-point improvement on this 33-point questionnaire score. So in the rest of the talk, I'm going to be talking about why these views are obsolete. And let's start with the review of evidence that was taken on by the committee at the Institute of Medicine, looking at the criteria for the diagnosis and the evidence behind them. So the chair of the committee, a pediatrician and lawyer and ethicist from the University of from Vanderbilt University, Ellen Clayton, wrote in the summary statement that ME/CFS is a serious, chronic, complex, multi-system disease that often can profoundly limit the health and activities of affected patients. I was on that committee, and we came up with a simpler, more streamlined definition that required several core symptoms. One was a substantial impairment in the activities that were well tolerated before the person became sick. Usually accompanied by profound fatigue, but it placed the emphasis on this impairment in activities rather than on the symptom of fatigue. The second core symptom that people had to have was post-exertional malaise, or PEM, and the third was unrefreshing sleep. And you could have either cognitive impairment or orthostatic intolerance. And those symptoms had to be present for at least 6 months, be present at least half the time, and have at least moderate severity. So it wasn't just somebody with a little bit of fatigue here and there. Post-exertional malaise is an increase in a variety of symptoms after physical activity, cognitive activity, or orthostatic stress. And we've also shown in our work that it can occur after biomechanical strain, like you'd get with a straight leg raise maneuver, as if you were testing for meningitis. The symptoms can include not just worse fatigue, but flu-like symptoms, lightheadedness, worse cognitive function, headaches, pain, light and sound sensitivity. And these are familiar to us in patients who have post-concussion syndromes. Patients recognize that PEM onset can not only be delayed by 24 hours, so they might not recognize what triggered it, but it can extend well beyond 24 hours in duration. So individuals who are affected by ME/CFS refer to this as a crash. And we've learned that there are gene expression changes in a variety of adrenergic, pain, and immune pathway genes after exercise that correlate with what patients are reporting when they have a flare in symptoms. And I want to show you one slide that emphasizes this. This was a study by Alan and Kathleen Light and their colleagues where they had people exercise for 25 minutes to 70% of their predicted maximal heart rate. It wasn't a full cardiopulmonary exercise test. And they were looking at gene expression changes on white blood cells that are shown on the far right in some of the sensory genes. So these are genes that are important for pain processing and pain sensitivity, adrenergic genes that are important in control of the circulation, and then a variety of immune genes. What you can see at the top is that they measured blood at baseline before the exercise and then several intervals afterwards up to 48 hours. And the healthy people at the top had very little change in gene expression on the white cells. And again, that gene expression was thought to reflect what was going on internally in other tissues, including muscle. On the bottom, you can see the massive difference with the ME/CFS patients who had symptoms that they reported peaking at 24 hours. And that was exactly when the adrenergic gene changes were something like 8 to 9-fold higher than they were at baseline. You can see that the sensory gene pathways were about a 3-fold increase compared to baseline. And then there was a lesser increase, but still much more than in the healthy people in the immune genes. And this work has been replicated. So this gives a biological credence to reflect the timing of patients reporting their symptoms. So something is going on that is well beyond the patient's control. When we sit down with patients, we use this diagram that we'll spend a bit more time on, but the point of this is that orthostatic intolerance is one of the most common and most treatable problems in ME/CFS. So let's talk a little bit about that. These are the common forms of orthostatic intolerance. On the left is somebody who has postural tachycardia syndrome, or POTS, which requires a 40-beat increase in heart rate in adolescents, a 30-beat change in adults, in the first 10 minutes of being stood up, standing against the wall, or on a head-up tilt table test. And it has to be not just a heart rate change, but these are people who have to have chronic orthostatic symptoms, and they can't have a drop in blood pressure, orthostatic hypotension, in the first 3 minutes upright. On the right is something we termed neurally mediated hypotension, but this is the same as vasovagal hypotension. This is somebody who is brought to a 70-degree upright position, head-up position on the tilt table, becomes immediately lightheaded and pale. And then at the 5-minute point, you can see blood pressure in the blue dropping precipitously down to below 50, which is not compatible with remaining upright. And at the same time, the heart rate slows as well. That is classic for this reflex response. This individual, because of the sudden drop in blood flow and oxygen to the brain, developed some brief tonic-clonic or seizure-like movements. The symptoms of orthostatic intolerance, as you can see here, are really quite multi-system, as expected for every place that the autonomic nervous system controls blood flow. So lightheadedness, syncope, and diminished concentration are common, as are headaches and blurry vision. And all forms of orthostatic intolerance that we know of have an increased prevalence of fatigue and exercise intolerance, particularly low impact exercise. So the symptoms on the left are thought to be because of a reduction in blood flow getting to the brain. The ones on the right are largely thought to be due to an excessive adrenergic response to that reduction in blood flow. The sympathetic nervous system is enhanced, and so people can get an orthostatic shortness of breath, chest pain, palpitations, tremulousness, and there's an increased prevalence of anxiety in those with orthostatic intolerance because the high rates of epinephrine and norepinephrine that you see as a response to the reduction in brain blood flow can also be used in experimental settings to stimulate a panic attack. So there's an understandable interaction there. Nausea and urination at night are also common. We had first gotten interested in this when running a diagnostic problems clinic in the early 1990s. And in seeing our patients with chronic fatigue syndrome or chronic fatigue as a symptom back to back with those who had fainting, we realized that they were really describing the same settings of symptom provocation, any kind of quiet, upright posture, standing in line, especially on a hot day. And so we began tilt testing patients and showed that not only could we reproduce their symptoms that day, but we could make them have a big drop in blood pressure like I just showed you. And with my colleagues, Issam Bouhalega, who was a fellow in pediatric cardiology from Saudi Arabia, and Hugh Hopkins, who ran the tilt lab, as well as Jean Kahn, who was the head of pediatric cardiology at the time, we went on to study a larger group of patients. The first case series was just a group of 7 patients, 4 of whom felt much better when they were treated with drugs to treat their hypotension. So we wanted to expand on this and studied a group of 23 adolescents and adults, compared them to 14 controls. And one of the most striking things was that when we brought them upright on a tilt table to 70 degrees, every one of the ME/CFS patients had an increase in the intensity of their fatigue, and really they reported having a bad day on the tilt table. They were lightheaded, they got hot, they had nausea, whereas the controls for 45 minutes in stage 1 were simply bored. When we looked at the number who developed hypotension, stage 1 is the first 45 minutes. If people tolerate that, the table goes down flat again, and they get an infusion of a different catecholamine, isoproterenol. Table comes back up for 15 minutes. Stage 3 is a slightly higher dose of isoproterenol. And what you can see is that 16 of the 23 ME/CFS patients developed hypotension in the first stage 1, whereas none of the healthy people did. Once you start giving isoproterenol, you can start provoking hypotension even in healthy people. So most centers have abandoned the stage 3 that we were using at the time. But in any event, the odds ratio for an abnormal tilt, if you had a diagnosis of ME/CFS, was 55. This is a huge number in medicine. We see acrocyanosis commonly in our patients. This is somebody who's doing a 10-minute standing test, and that's the color of her hand after 5 minutes, with my hand as the color comparison. On the right, I've checked for capillary refill, and normally you'd expect to see blood returning to those white areas within 3 seconds. I pressed on this girl's leg, I stepped back, picked up my phone, found the camera icon, focused it, and took the picture. So something like 6 or 7 or 8 seconds had passed, and still there was no capillary refill. So we think this is present in about 75% of our patients. In that study I was telling you about, one of the things we did after confirming that people would have a drop in blood pressure was that many of them wanted a trial on the treatments typically used for recurrent fainting. And we gave them openly, not in a blinded fashion, either Florinef or beta blockers or midodrine or other medications that were used for recurrent syncope. And these individuals were quite impaired. They had a wellness score of 35 out of 100 on average at baseline, when 100 is as good as you could imagine feeling, and 0 means dying. After 4 months of treatment, the improvements brought that mean wellness score up to 70. And you can see some people really did strikingly well. Others had a more modest improvement. When you look at the evidence on orthostatic intolerance in the pediatric form of ME/CFS, our initial paper published in The Lancet had a prevalence of 7 out of 7, so that all of the patients that we found who had more than 6 months of fatigue were positive. Julian Stewart replicated some of this work using an 80-degree head-up tilt test for 45 minutes. And he found that 18 of the 26 patients in his group had postural tachycardia syndrome. 22 had that NMH response. So obviously some of them had both. He found about 3/4 of them had acrocyanosis, and overall the rates of orthostatic intolerance were close to 100%. Tanaka, using just a 7-minute period of active standing, showed that you could have delayed recovery of cerebral oxygenation using near-infrared spectroscopy. So that occurred in 3/4 of the ME/CFS patients and just 10% of the controls. Vigard Willer in Norway felt that a 20-degree head-up tilt angle was more acceptable for adolescents. And this, in fact, accentuated the differences between the healthy people and the patients. Healthy people find that a 20-degree head-up tilt is a bit like a snooze on the couch on Saturday, whereas the patients had aggravation of symptoms and a much higher sympathetic tone looking at heart rate and blood pressure changes. So all of the pediatric studies have shown a higher prevalence of orthostatic intolerance. That was not the case for the adult data at the time of the Institute of Medicine report, but new data have emerged, largely triggered by some observations by Linda van Kampen and Frans Visser in the Netherlands. They came up with a new way of measuring blood flow to the brain using a Doppler probe on each internal carotid artery and each vertebral artery. So it takes about 30 seconds to acquire the imaging from each of those vessels. So over the course of 2 minutes, you can actually get the blood flow through those 4 vessels added up to get total cerebral blood inflow. So they show that if you're lying flat, this is the pattern of the Doppler image, and you can see that standing, this individual has quite a drop-off in flow through the vessel, and you don't have to be an ultrasonographer to see that difference. I met them at a conference in Bristol, and in 2017, and we began working together, enjoying that collaboration, but also I helped a bit with the writing. But these are all their data, and they found that in a massive study of 429 ME/CFS patients, and that number approximated the number that we summarized from the existing literature in the Institute of Medicine report. So this is a huge study sample. When they had them upright on the tilt table for 30 minutes, 28% had POTS, 14% had a delayed orthostatic hypotension, so a drop in blood pressure after the 3-minute point. But something like 58% had a normal heart rate and blood pressure response to that upright tilt. And people might have been tempted to say, well, then there's nothing wrong, go home, we've got nothing for you. But what they were able to show was that compared to healthy people, who after 30 minutes upright have a 7% reduction in their brain blood flow compared to their supine values, if you take the entire group of 429, they had a 26% reduction, so almost a 4-fold greater reduction in brain blood flow. And when you separate that 26%, when you divide them into the ones with orthostatic hypotension or POTS, they had a somewhat worse drop in cerebral blood flow. But the people you might have been tempted to tell there was nothing wrong, nonetheless had a 24% reduction in brain blood flow. So it's probably no wonder that they feel lightheaded, can't think well, and can't find the right word in sentences. So what do we have to treat them when they have this orthostatic intolerance? Well, the 3 main problems are that there is inadequate vessel constriction. People pool too much blood in their limbs when they're standing, as you can see from those pictures of acrocyanosis. So then one can pick vasoconstrictor drugs. So drugs like midodrine, any of the stimulants that we use for attention deficit disorder, and some of the SSRI and SNRI drugs have some vasoconstricting effect. Droxidopa is available more for adults with orthostatic hypotension, but sometimes you can get it for children. Then the second mechanism is that people are often volume depleted, so we want to try volume expansion with sodium, usually orally, occasionally with a bolus of normal saline IV. But the main drug that expands blood volume is fludrocortisone. Clonidine has an interesting capability of doing this as well for people with low orthostatic tolerance. Birth control pills can help, as can desmopressin. And then the last category is if there's excessive catecholamine release affecting heart rate, you can try drugs that will block that or block the release of the catecholamines. And those are listed at the bottom, and they include the beta blockers, sometimes the SSRI and SNRI drugs, ivabradine, which just affects heart rate, and pyridostigmine bromide. I've got some references at the end that will give you the doses for using these medications. So let's look at the clinical presentation, the epidemiology, and the impact of this illness on our pediatric patients. So I'll give you an example that introduces the symptom profile in this 16-year-old, and then we'll come back to how she did over time at the end. This is a young woman that was healthy and active until 9 months before coming to see me. She had the insidious onset of fatigue, not with any apparent infection. And by the time we saw her, she was sleeping 12 to 14 hours a night and would awaken quite unrefreshed. And her mother commented that it was very difficult to get this girl going in the morning. You really had to waken her up several times before she'd rouse and get out of bed. She would then take a shower, but then have to lie down again after showering. If she had a relatively active day, she had to rest for the following day, so suggestive of post-exertional malaise. She had difficulty concentrating that was new, her muscles were sore, she had headaches and was lightheaded, and as a result was unable to attend school. So that's often how patients can present. We know, though, that a post-infectious onset is quite common. The best studied of the illnesses that triggers ME/CFS is infectious mononucleosis. And 10 to 13% of people with mono meet the criteria for ME/CFS after 6 months. In mono, the main risk factor has been the severity of the initial viral infection. And we used to think that there was a gradual or insidious onset in up to 40% of adolescents. But the COVID pandemic has made us question that, because we now know that you can get long COVID ME/CFS after either an inapparent initial infection or a very mild initial infection. So what we don't know with the pre-pandemic patients is how many of them might have had a viral infection that they didn't even recognize as the trigger. In any event, the illness is uncommon before the age of 10. It has been reported in children as young as 2, but there's a big peak in the incidence of the illness in adolescence, just as there has turned out to be for long COVID. There are 2 peaks in incidence in the Scandinavian epidemiological literature at 10 to 19 and then 30 to 39. The point here being that this doesn't just keep getting more common the older you get. There's a strong female to male ratio of about 3 or 4 to 1, and there are heritable components to ME/CFS. It's much more common to see the illness in both monozygous twins than in both dizygous twins. We recognized back in 1999 that it was much more common for us to be seeing patients who had Ehlers-Danlos syndrome, typically the classical or the hypermobile type, in our clinic. So when we looked at those who had joint hypermobility that was non-syndromic, that is not related to EDS, we saw a 3-fold increase in the prevalence of joint hypermobility, which obviously preceded the onset of their ME/CFS because it had been a lifelong trait. In the top right, you see the histogram of the Beighton scores, which are used to measure joint hypermobility. A score of 4 or higher is considered consistent with hypermobility. And in the yellow, you see the healthy patients who had a mean Beighton score, median Beighton score of 1, and 24% of them had a score of 4 or higher. These are likely to be the kids in high school who don't have an illness, but have things like they're good at dancing or swimming or gymnastics or cheerleading, where their hypermobility is an advantage in those activities. Contrast that with what looks like a completely different population distribution in blue. 60% of our ME/CFS adolescents have scores of 4 or higher. So this is a striking difference that was highly significant statistically and has been confirmed by virtually every other group. Occasionally, you'll see people who have not done the Beighton scores correctly or have some other imperfect measure of joint hypermobility, claiming that this relationship does not persist. We have not seen any evidence that's compelling to suggest anything other than what we originally reported back in 1999. And most people are now finding that joint hypermobility is also, not surprisingly, a risk factor for long COVID. The impact of the illness is pretty substantial. The severity in adults who are given questionnaires is comparable to multiple sclerosis or congestive heart failure, and many people are disabled. In pediatrics, it's the most common cause of prolonged school absence in developed countries. And when we did a cohort study recently, we looked at the impact of this on health-related quality of life using a questionnaire called the PEDS-QL that is commonly used in research studies. And you can see on the bottom left that the CFS patients had a much lower score than our healthy controls did. I then compared the same questionnaire scores among people who were studied at the University of Cincinnati Children's Hospital, who were attending clinics for their cystic fibrosis, eosinophilic gastroenteritis, diabetes, and sickle cell disease. And I'll show you where their scores fell. And I think most people are surprised to see that the ME/CFS patients had the lowest scores of all of these groups of patients with chronic illness. Let's go on to talk about the clinical evaluation and evidence-based options for treatment. We obviously depend entirely on the history to elucidate the symptoms of the illness and the classic pattern where increased activity or upright posture are followed by post-exertional malaise. We supplement that with questionnaires because I think it's very difficult to get a good sense of what people's cognitive function is like just from the history. They can usually rise to the occasion. And we also check for evidence of depression using the Beck Depression Inventory or something like it. The physical examination has to be really detailed and complete with a careful neurologic examination. We do a Beighton score of hypermobility, which takes about a minute or two. And then we check range of motion on some tests that are usually used by physical therapists. And if you're not comfortable with doing these maneuvers, and most of us weren't trained in those, then that's where your physical therapist colleagues can be very helpful. The screening laboratory studies are familiar to those of us in pediatrics because these are the studies we send on anyone who's not thriving. So we get a CBC with differential, some measure of inflammation like an ESR or a CRP, a comprehensive metabolic panel, and then thyroid studies, not just the TSH. We usually get a free T4 as well, a urinalysis. And then because they're associated with fatigue, we check for iron deficiency, vitamin B12 deficiency, and we screen for celiac disease because fatigue can be a single symptom of celiac disease. Usually, we don't see patients in our clinics who have Lyme disease that has persisted. They've almost always been picked up by somebody else because of their acute symptoms earlier. We don't check immunoglobulins or an ANA on everybody, but we would if there are other features consistent with those abnormalities, but really limit it to the main failure to thrive type laboratory studies and then get other labs as indicated. In terms of the history, we want to know, was this an abrupt or gradual onset, and did it occur in relation to another illness or other event, including trauma? We find out about the patient's typical day. What time are they up in the morning? What time do they go to bed? How many hours of sleep per day? Is it refreshing? And do they have to take naps during the day? We want to know what impact it's had on their daily life. So has it affected their ability to attend school, or if they're older, to work? How many missed days might they have had? And are they still able to participate in any way in sports and social activities? We want to know in questioning about post-exertional malaise, do they have symptom flare-ups after activity or after, say, standing in line going shopping? And our joke with our trainees is that if you've got an adolescent who can't tolerate going to the shopping mall, then you've got an organic illness until proven otherwise. And so asking about how people do with shopping can be quite revealing. We also look for symptoms of orthostatic intolerance. Not all adolescents can recognize that their lightheadedness is lightheadedness. They sometimes refer to it as a head rush. And not all of them notice that associated with that, they feel unwell. So we ask about specific things like, are you intolerant of standing in line? How do you feel with shopping? How do you do standing still? How do you do in hot environments, or for young women with their menstrual periods, which often are capable of aggravating the fatigue? A typical stimulus that is poorly tolerated is the hot shower, like in the 16-year-old I presented earlier. Many patients have to sit down or lie down in the shower or lie down to recover afterwards. We also ask about whether they have any craving of salty foods. And then with attention and cognition, we want to look at whether they've got adequate focus, whether they have word finding problems or processing problems. We perform an in-office passive standing test in all of our patients with this degree of chronic fatigue and impaired function. We get a supine blood pressure and heart rate every minute for 5 minutes lying flat. Then we have them stand with their upper back leaning back against the wall, and we record the blood pressure and heart rate every minute for 10 minutes. We ask them not to move and fidget too much, and we try to minimize the amount of time talking. They then return to a supine position. We check blood pressure and heart rate every couple of minutes. Throughout the test, we're looking for not just changes in heart rate or blood pressure, but more commonly for whether they get an increase in the intensity or severity of any of the symptoms that you see in the bottom left: fatigue, lightheadedness, brain fog, headaches, pain, nausea, sense of being warm, sweating, trouble breathing, and then we look for acrocyanosis as well. Among the clinical discriminators of fatigue, you can use some of the items on this list. So if patients have neuromuscular disease from muscular dystrophy or something like myasthenia gravis, they are truly weak. Our patients with ME/CFS usually do not have a reduction in strength. They sometimes use the term weakness to describe their fatigue, though, but their muscle strength testing is usually normal. In patients with obstructive sleep apnea, you're more likely to see daytime somnolence and to hear about a history of snoring. In those with heart disease and lung disease, you get shortness of breath during the effort. In contrast, our ME/CFS patients can push through an activity. They feel the impact of it afterwards. Patients with adrenal insufficiency are uncommon, but they will likely have a much more rapid drop in blood pressure when they're stood up for 2 or 3 minutes. And usually the blood work will show a drop in their serum sodium, at least in the early part of the illness, with an increase in potassium later. Bronzing can be common, but it's found to be a later appearing symptom or sign in adrenal insufficiency. And then Dan Hafez and a number of others, including our group, have found that there's a subset of patients who have a Chiari malformation with crowding at the back of the skull, or cervical spinal stenosis, either acquired or congenital, and even ligamentous instability at the skull base. That's going to be more likely in those who have Ehlers-Danlos syndrome, but these patients usually report an occipital headache, neck pain, brisk reflexes, limb paresthesias, and a Hoffman sign, which is elicited by flicking the distal part of the third finger, and you're looking for an involuntary flexion of the other fingers. And that can be a sign of some kind of cervical spinal irritation or compression. So among the red flags for serious conditions other than ME/CFS, you can see on the right a picture of one of our patients who'd had 6 years of symptoms, and finally had an abnormal Hoffman sign, which made us get this cervical spine MRI. And you can see that the distance here in the AP diameter of the spinal cord, which should be 13 millimeters or more, was only 8 on this MRI. And here at C6-7, this girl had a bulging disc that had nowhere to go. Might have been quite benign in somebody like me with a normal spinal canal, but her spinal canal narrowing led to compression of the spinal cord at this site. She responded beautifully to an artificial disc replacement at this point and was able to resume all of her activities within 6 months of recovering from that surgery. Weight loss is uncommon in our patients, the one caveat being that patients with median arcuate ligament syndrome or MALS can develop weight loss, but most of the time our patients maintain a stable weight. Fevers are uncommon except in the very earliest part of a mononucleosis syndrome. Sleep paralysis or cataplexy are uncommon, so we don't see features of narcolepsy very commonly in those with ME/CFS. They typically don't have clubbing or erythematous swollen joints, and we do look for these overlapping abnormalities on the neurologic exam. When we're talking with our patients, we use this diagram that I showed you earlier because many of the factors around the outside of the circle can affect both the orthostatic intolerance and the ME/CFS symptoms. So people who are quite impaired, it's not surprising when they get a secondary depression related to their lack of adequate function. Anxiety and orthostatic intolerance have a feedback loop effect on one another because of the high catecholamine state in response to being upright. We see a lot of motility problems in the gut. 30% of our patients have food allergies, typically a milk protein intolerance, which is signaled by epigastric pain, reflux, and early satiety. We're paying more attention, as are many other groups, to the presence of mast cell activation syndrome, where you might see a lot of intolerance of different foods and medicines, as well as a lot of facial flushing, hives, and itching. Obviously, any new virus can aggravate the orthostatic intolerance. We don't see very many people who have true immune dysfunction, but this is one of the speculations behind the occurrence of ME/CFS, is that there's something subtle in the immune system response. I'll show you in a minute some of the movement restrictions that we identify with our physical therapist colleagues, an important one being thoracic outlet syndrome, where people get symptomatic with arm fatigue and numbness and tingling with their arms overhead. Headaches are a common symptom. I've mentioned the subset who have a neuroanatomic problem. Ehlers-Danlos syndrome and joint hypermobility spectrum disorder are both very common, and those patients are more likely to have vascular compression syndromes, including the May-Thurner compression of the left common iliac vein by the overlying right iliac artery, MALS, nutcracker syndrome, and even Eagle syndrome, where you get compression of the internal jugular veins as they exit the skull. Hyperhidrosis is another condition that can have a high prevalence of orthostatic intolerance and can contribute to impaired quality of life. So in terms of management, in part because we have not had coordinated clinics that collaborate around the country as we have for pediatric HIV or pediatric cancers, and many other subspecialty conditions for that matter, we haven't had lots of clinics, so there haven't been any clinical consortia that have tested treatments. But that doesn't mean that you have to be a therapeutic nihilist. Standard forms of symptomatic therapy can be quite effective for the orthostatic intolerance, as I showed earlier, for migraines and headaches, for different types of pain, for the menstrual dysfunction that the young women might have, for sleep disturbances, for low mood and anxiety problems, or any other comorbid condition. So there's lots that we can do symptomatically to help these patients. I mentioned the prior enthusiasm for cognitive behavioral therapy. This was proposed as a curative treatment, but that is no longer accepted as part of national treatment guidelines, either in this country or in Europe. The reason is that the treatment effect sizes, as I showed you on that slide from the PACE trial, were quite modest. None of the trials enrolled people who were severely affected. And in the PACE trial, the investigators changed the outcome measures midway through their analysis because they weren't seeing what they'd been predicting. And so in order to get enrolled in the trial, you needed a physical function score of 70, where 100 is as good as you could be. So anything below 70 got you into the trial. And then when they reported on how many people had recovered, patients only needed to have a score of 60. So you could have a 10-point deterioration in your physical function, and they scored it as recovered, which is clearly and patently absurd. And so this trial has been reanalyzed according to its own pre-study published analytic plan, and virtually no difference from CBT was found. We also know that rigid advancement of graded exercise, which is part of the of CBT, often can cause harm by provoking post-exertional malaise. As an example of the kinds of studies that were done on CBT to make this point, one of the pediatric studies randomized people to 10 one-hour sessions of CBT, and the control group got nothing. They simply stayed on the waiting list, so they didn't have the same amount of attention. And David Tuller, a journalist at UCal Berkeley, wrote in a very colorful way, here's what this BMJ study proved. 10 sessions of something lead to more reports of short-term benefits than no sessions of anything. But 10 sessions of what? Maybe 10 sessions of poker playing, or 10 sessions of watching Seinfeld reruns while holding hands with the therapist and singing The Girl from Ipanema in falsetto would have produced the same results. Who knows? To flatly declare that their findings prove that CBT is an effective treatment without caveats or an iota of caution is a huge and unacceptable interpretive leap. Let me mention a couple of the findings from our experience that help us with the underlying rationale for treatment. We looked at cow's milk protein intolerance in our cohort study that had 55 patients. 17 of them met the study criteria for that problem. So what were the study criteria? Well, you couldn't have had an immediate anaphylactic reaction to milk. You had to have at least 2 of this triad of symptoms of epigastric pain, reflux, and early satiety. And you had to have improvement in these upper GI symptoms on a milk-free diet, as well as at least 2 recurrences of symptoms starting at least 2 hours after open re-exposure to milk. And what was interesting was that compared to those who were milk tolerant with ME/CFS, the ones who were milk sensitive had significantly worse health-related quality of life at baseline, but after 6 months of being on the milk-free diet, they had caught up to the other group. So this gives you a very practical thing to do in patients who have that triad of symptoms, many of whom claim that many of them know that they can tolerate milk and like it. And so they're a bit grumpy when you tell them that they're going to need to try going off milk protein. But after they've seen how much better they feel, they're willing to persevere with this diet. I mentioned the movement restrictions. We did in the cohort study 11 different maneuvers that are shown on the left part of this slide. One was called the seated slump test, where the leg is brought up to horizontal while they're in a seated position. Ankle dorsiflexion, straight leg raise, upper limb neural tension tests, prone knee bend, and prone press up. And on all of these, the prevalence of the problem was higher in the ME/CFS patients than the controls. And on this slide, I've shown you the ones that were statistically significant. And we have another cohort study that we're doing currently in an attempt to see if we can replicate these findings. So we don't know why people are tight in the beginning. It isn't related just to their inactivity. It could be related to some neural swelling at the time of an infection. We don't know, but this tends to improve over 2 years of multidisciplinary treatment. Here's the range of motion score. If we take all 11 maneuvers and give them a normal versus abnormal score, you can see that our patients had a significantly different and much higher prevalence of range of motion problems than the healthy kids did. On the right is that same group of patients showing them at the start of treatment, and then in black after 2 years of the multimodal therapy. We've also found, as I mentioned, people with neuroanatomic problems. So this was a small case series showing improvement in patients who had severe ME/CFS symptoms after recognition that improved after surgical treatment of their cervical spinal stenosis, like the patient I showed you earlier. Others have described associations of different types of vascular compression problems with POTS and other forms of orthostatic intolerance. So here is a picture of the anatomy of May-Thurner syndrome, where the overlying, more muscular right iliac artery sits astride the left common iliac vein, pushing it up against bone and leading to backup of blood and insufficient return of blood from the leg, but also collaterals that form and cause pelvic pain. And a condition called pelvic congestion syndrome overlaps a lot with ME/CFS. These are patients who report fatigue, limiting their activity, dizziness, brain fog, and hyperhidrosis, among other symptoms. Steve Smith, who's a pioneering interventional radiologist, actually did pre and post studies after treatment of these pelvic vein problems. And I'll just draw your attention to the orthostatic hypotension score on the right, which you can see 49% of them met criteria for orthostatic intolerance before they were treated with interventional radiology maneuvers, only 13% afterwards. So this can lead to very nice improvements in overall function. Back to our 16-year-old, she had on her examination primarily acrocyanosis, and she had a Biden score that was elevated. Her blood pressure was pretty normal. With a 10-minute standing test in the clinic, she had a 41-beat change in her heart rate with provocation of her typical symptoms. So if she came in now, we wouldn't go any further. We'd diagnose her with POTS and move on to treatment. Back in 1995, when she was seen, we were putting everybody on the tilt table, and that provoked classic symptoms of fatigue, warmth, lightheadedness, nausea, sweating. And after an initial increase in heart rate to the 120s, she developed pre-syncope at 17 minutes. Her blood pressure fell to 78/48, and she had an associated slowing of her heart rate at that time. So she had both POTS and neurally mediated hypertension. We treated her with a higher intake of salt and fluids, as well as fludrocortisone. And because there's excessive potassium loss in the urine because of fludrocortisone, we put her on a potassium supplement as well. She had an improvement in all of her symptoms within 2 weeks and began resumed working on her 2 jobs, one of which was feeding livestock at the family farm. And she was able to spend more time with friends. By a couple of months later, she was able to resume schooling. Fatigue would only occur after 45 minutes of swimming, which was pretty good. And on a repeat standing test on treatment, she had only a 10-beat increase in her heart rate. She would get occasional flares of fatigue when her allergies were active. We had done a randomized trial of Florinef in adults that showed that it didn't work in ME/CFS patients. And when we would go back to the clinic and take people off their Florinef, as we did in her case, she would get an immediate return of really impressive fatigue whenever we stopped the drug, even though she had good levels of exercise and physical conditioning. So the Florinef was helpful in her case. Off the medication, her wellness score was in the 50 to 70 range. On the medication, it was 85 to 90. As she reached her 20s, her blood pressure started creeping up, indicating that she no longer needed the fludrocortisone, and we stopped it. She's now in her 40s, with married with 2 kids, working full time, and really has had one of the better outcomes that one can see. This is the overall wellness scores in our cohort of 55 patients. So this was with individualized treatment, getting them from a mean wellness score of around 50 to up to about 75. But that means that not everybody gets better. And I want to close with a case of a 25-year-old who started getting sick when she was 9, much worse after a series of sinus infections at age 13. And she has been unable to attend school since the grade 8 year due to her symptoms, and is now mostly housebound. We've recognized a number of other comorbid conditions in her case, but have not been able to affect her overall function. She has POTS. She's got a low IgG and gets subcutaneous gamma globulin replacement. She had a low carnitine. When we normalized that with supplements, nothing changed. She has migraine. She has recurrent hives suggestive of mast cell activation. She has a variety of problems with GI motility, and she has the thoracic outlet syndrome problems. So in conclusion, I hope I've convinced you that ME/CFS is a serious, chronic, complex, multi-system disease that often can profoundly limit the health and activity of affected patients. And we are seeing the same pattern in patients post-COVID who have these kinds of severe impairments and meet criteria for ME/CFS. So in contrast to the earlier views of the early 1990s, the physical examination is abnormal. You can see acrocyanosis in 75%, tachycardia or hypotension with orthostatic stress in more than 95%, joint hypermobility in 60%, and the kind of movement restrictions that a physical therapist can identify in more than 80%. Cognitive behavioral therapy is not the enemy. It can be helpful in a subset of patients with anxiety or depression or trouble coping with chronic illness, but it is certainly not a curative treatment. Many of the symptoms of ME/CFS are amenable to established therapies, but as the last couple of slides showed, effective treatment for severe ME/CFS is still a critical need. And I think it's important, especially in the COVID pandemic period, that we need a much greater expansion of clinical care in order to address inequities and make sure every adolescent who has this illness has a chance at getting treated. Let me leave you with some resources. I mentioned earlier that the medication doses for a variety of different problems, including orthostatic intolerance, but not limited to that. So we have, in this pediatric primer, we have medication doses for pain and for migraines and headaches. And this is available open access, so you can download it free of charge. It has examples of letters to share with the school asking for accommodations. It has an example of the standing test recording form. So it has lots of very practical information for practitioners. Some of the resources that are out there are the lengthy evidence review by the Institute of Medicine Committee. I've got chapters both in the Principles and Practice of Pediatric Infectious Diseases and in the Neinstein Adolescent and Young Adult Healthcare book. Kathy Rowe, who's no relation to me, is a very experienced, excellent clinician from Australia, and she's written about long-term follow-up of young people with this who attended a pediatric outpatient service in Melbourne, Australia. We have a website in which you can download a number of the papers that have emerged from our clinic. So here's the QR code for that and the listing for the website. So we'd also like to invite everybody to join us in August. We're going to do another webinar that's more detailed on managing pediatric orthostatic intolerance. Our work at Johns Hopkins would not have been possible without the support from the Sunshine Natural Wellbeing Foundation that endowed my professorship, from the Boyce and Caldwell family endowed funds, from our team that includes Renee Swope, who has 3 kids with this problem, Dr. Broussard, who's our adolescent medicine specialist, Dr. Azola, who is helping taking care of the older patients, Megan Swope is our research assistant. Rick Violand has been our PT collaborator, and Colleen Marden was the volunteer research coordinator for a number of years, especially during the initial cohort study. We've been very fortunate to have some excellent summer students listed here. And as you see in the bottom, Emily Steffensmeyer is there with Rick Violand. She's organized a fundraiser that helps us continue with our clinic. And again, we would not have been able to do this without the support of many, many families and patients. So I'm going to stop there, and we will reconvene in August.
Thanks again, Dr. Rowe, for that presentation. And a reminder to everyone to send in questions to meactmaryland@gmail.com. At this moment in our program, we'd like to switch to a panel of those with lived experience with pediatric ME/CFS, which includes former children, now adult ME/CFS people, as well as caregivers. I am one of these people. In this first event discussion, we talk about our experiences with symptom recognition, diagnosis, encounters with the medical system, and education. Our aim is to provide a holistic impression of a child presenting with symptoms of ME/CFS. That said, the patient population that you're about to see is not demographically representative of the population of ME/CFS, and instead represents a narrow group of white women with economic and educational privilege. Also, although the panel does represent a range of severity in current and past experiences, the severity cannot be adequately noted based on a single interview. As our series proceeds, the panel of lived experience individuals will change with every webinar, and our chapter is committed to patient equity. Let's get started.
We're going to start today by introducing you to our panel and who will tell you about their experience to pediatric ME/CFS in the past. Bridget, can you get us started?
Thanks, Gwen. My name is Bridget Collins. I got pediatric ME at the age of 11. I've been sick now for 30 years.
I'm Whitney Fox. I started showing symptoms of ME at age 11 with mild ME symptoms. I've had ME now for about 24 years. It was undiagnosed for 19 years.
Hi, I'm Lauren Bean. I became acutely ill in 1998 when I was 15. Although now in retrospect, I'm aware that I was having symptoms for probably about a year before that. I actually was able to get diagnosed with chronic fatigue syndrome, it was then called, fairly early for a patient of my age at that time.
I'm Diane Bean and I'm Lauren's mom. And I'm sort of here to add the parental perspective on dealing with a child with ME.
And I'm Denise Lopez Mahano, and I am the parent of 2 adult males who have ME, who've had it since 2005 and 2006 when they were 12 and nearly 15 years old. So they've been sick for 19 and 18 years.
Thank you all for joining us. One of the first things we want to talk about is how we recognize our symptoms when we're children. Many adults struggle to describe how they're feeling when they first develop symptoms of ME. What was it like for you as a child? When you began to feel unwell, how did you feel and how did you communicate what you were feeling? And for our caregivers, what were the first signs for you that something was off with your child or your children?
I started out having a lot of sore throats. I was tired. I had headaches. I knew things were wrong. I felt not as smart and feeling not like you and not as smart and underperforming is horrible. It's a horrific thing to feel.
I also experienced a lot of strep throat. Sometimes the test would come back positive, but not all the time. And they would usually give me antibiotics. It's worth mentioning that I was living overseas at the time, but we thought we had a good family medicine doctor. I was having a very hard time concentrating. I started developing more like nausea and upset stomachs to foods that I really hadn't had a problem with before. And my temperature regulation became very strange. I was cold, but I was still sweating and I didn't understand why. Clearly, I knew something was not right, but for some reason, it didn't occur to me that these things were all connected because they all seemed to be in different parts of my body.
It started for me in middle school, and I had such a hard time waking up for school. If I tried to take a shower in the morning, I would have to lay back down and rest before being able to get dressed. I had a hard time sitting up in the desks at school, and I would be like slouching down, leaning on things a lot. I quit dance classes and mainly put all my energy into keeping up with schoolwork and then sleeping in till 11 or 12 on the weekends. Never felt rested. And I knew something wasn't right, but it was the frequent sore throat. Sometimes it was strep, sometimes it wasn't. Allergy symptoms, but nothing definitive really showing up on tests. So I just pushed through.
I want to echo what Whitney said, that also I started having more sleep problems. Like I had a hard time falling asleep and then a hard time waking up.
My son's also had an awful lot of trouble with sleep. In fact, in the beginning, my younger son got sick before my older son did. He was sleeping sometimes 20 hours a day. He just could not get up. There was no way.
I definitely had a point where I was sleeping 20 some hours a day. I went to school, came home, went to sleep, got up, went to school, came home, went to sleep. Like that was my year. And I slept during school.
As a parent, one of the things that I noticed was how difficult it became for Lauren to do homework. And she was also an honor student and an athlete and was in extracurricular. She had a very severe case of mono, and she just didn't get better. And we actually moved that summer back to the United States. So she was starting a new high school, and she had recovered to the point where she could go to school and actually even made the field hockey team. But then after that, it was just downhill until one morning in February, she really couldn't get out of bed and walk up half a flight of stairs to the kitchen for breakfast. And of course, the blood tests were for the most part normal, except maybe for thyroid. And we started on the journey of, well, could it be depression because it's a school change and maybe she's school phobic, and all of these things that we knew was not true.
I'm glad you're talking about the encounter with the medical system. Let's transition to talking about what that was like with PME as a child. And let's start with our caregivers and what they've witnessed bringing their child and the recommendations they have.
My younger son had a very abrupt onset of ME, and my older son had a very gradual onset. And it was very hard to figure it out. The first symptoms that my older son actually had were because of orthostatic intolerance. He fainted. And it was only my hand between his head and the sidewalk that prevented him from getting a concussion. And then from there, he just went downhill gradually. With my younger son, we were extraordinarily fortunate in that we had a primary care physician who listened, who knew my sons well enough that he knew that this was not, whatever was going on was not typical for them and was an unusual presentation for the people he knew and cared for. He ran a lot of tests. He actually did a NASA lean test, and we're talking back in 2005. He actually did a NASA lean test and diagnosed my younger son with orthostatic intolerance. And had a few things that he could suggest, but he didn't have an awful lot. He was very supportive, but he couldn't do very much for us. It was a nurse in his practice, though, who said something to the effect of, you really need to get on this kid. We've got people with chronic fatigue syndrome who work full time. And I was appalled. There is a range of severity for almost every illness, and especially in this one. And she had no clue. And she had no clue, I don't think she had any clue how much that hurt and how inappropriate it was for her to say something like that.
In fairness to the practitioners, there wasn't a lot available for dealing with pediatric chronic fatigue syndrome. So I'm so thrilled that Dr. Rowe is doing this webinar, and that those of you in the medical field who deal with children can learn about the symptoms to look for. The problem with that kind of dismissive approach is, of course, these are kids. And the doctors are the experts. And when the doctors tell him not to be concerned, or that they're not concerned, instead of validating what they're going through, it's so difficult on their self-esteem. And on their parents' self-esteem, I would add, because there are, more than one doctor who I'm sure thought I was a Munchausen mom, because I was advocating for her.
Diane, I don't know if it's the same with you, but I felt as though because I was standing up for and believing my children, there was something about me that wasn't right. That
Legitimate.
I should believe the authorities as opposed to my children. Why didn't I believe the authorities? Why was I taking my kids' word over theirs? But I trusted my children, and I still trust them.
I had that same experience. I wanted to believe the doctors because I was hoping that they could provide us with a road for her recovery. Something is wrong. So, of course, what I would say to the medical professionals is look for the patterns, look for these specific symptoms, and above all, believe your patients.
And be supportive.
One of the things I think with kids is that we so often fall into this trap that kids get better. I think even more than with adults is kids get better because of the fact that they're kids and for a lot of things they do. So when we're with these diseases where they don't, it's harder to make the adjustments. I know for myself, it got to the point where I had chronic muscle wasting. I was down below 90 pounds. And I still had people telling me I was going to be fine. And I was literally dying in front of them. And I'm like, are you sure? It's okay. I ended up with a great doctor. He was awesome. He helped me out.
You knew as a child that something was wrong. And for me, with a mild or more gradual onset, I just wanted to be told that I was okay. It created this really weird dynamic for me where I didn't trust the doctor, but at the same time, I wanted to believe them.
I know that's really hard for a lot of people. That first time you go into the doctors and something's wrong and you're ready for them to tell you what is wrong because you've trusted them and believed them your entire life.
Interacting with the medical profession isn't something that we're taught how to do. And unfortunately, a lot of patients have to learn how to do that interaction and how to advocate for yourself.
I was kind of in between where Whitney and Bridget were. So I really saw the doctors as authority figures. One of my doctors first noticed that I was tachycardic fairly early on when I was just in for a regular appointment. I had the tilt table test done with Dr. Rowe, and that was something where I felt like, okay, this is some part of an explanation. It may not be the whole explanation. And it did help because he was an authority figure. I had had a lot of symptoms, but as my mom mentioned, all these different specialists, it was sort of like, I didn't connect the symptoms, and it would have been great if you're seeing a medical provider, if they could say, well, do you have any of these other symptoms? Because this might be part of the pattern.
Another thing that I think is very important is kids and language. And children may not have the language to describe what's going on and may not know what's normal or not normal for their stage of development. So it's important to ask questions that can elicit those answers. You're not feeding them answers, but if you ask questions in such a way that they can say, yeah, that is something that happens to me, or no, I actually have this other experience that happens to me, can be very helpful. I think also some of the cognitive things as well. When my younger son got sick, one of the things that told me immediately that there was something seriously wrong with him was he could not do the mental math at the age of 12, that at 5 was totally effortless for him.
Yes, I'd love to talk about schooling and what schooling was like for you.
as people with ME or for your children? One of the purposes of diagnosis is to get accommodations, and for adults that might be work, but for children, that's for school. Were you able to get accommodations at all? Were they helpful? Were they not? What was the hardest part about schooling when you were a child?
So one of the hardest things in high school is that you weren't allowed to go to the nurse during school to rest more than once, I think it was once a month. I went to a private school, and the workaround that was unofficial was that I could rest in the chapel whenever. So you could find me there a lot. But the accommodation I managed to get was that my senior year, I dropped a class and I had to work very hard to drop and not pick anything up, and could have an hour and a half period twice a week where I started school late so I could stay home and sleep an extra hour and a half, which was extraordinarily helpful. And then it wasn't official with the school, but through teacher by teacher basis, if I needed extra time to finish papers, I got that as well.
When I first got sick, I lived overseas. At that point, didn't really ask for any accommodations early on until I got mono. They did give me an adapted schedule for my final, so I didn't have to take quite so many on one day. And then when we came back to the States, I sort of hoped that I would be able to go back to school full time because I thought, the mono's over now. And I sort of went pretty much downhill from the start of the year. They allowed me to do some homeschooling. The teachers themselves couldn't fully wrap their heads around what was going on with me. Why was this hard for me?
We got her an IED plan, but what none of us really understood at the time, mental energy is using a lot of energy. So it was confusing to her and to the teachers when she's reading in bed where she's not physically moving, how that could be so exhausting. Post-exertional malaise is not just for physical activity.
It's really interesting you pointing out the mental exertion part, Diane, because I think that's how I self-accommodated being undiagnosed. I sacrificed all the physical and social activities so that I could do my schooling and get good grades. Recognizing ways that children are practicing pacing without maybe having the language to call it pacing, having frequent absences I was mindful of and tried not to have them too close together. So it was this calculation of, even though I don't feel good, can I get out of bed? I don't think that's normal for a child to be thinking that way, especially about school.
My sons were diagnosed pretty early on, and they were never able to finish high school. They were just never well enough to finish high school. They were only able to process about 20 minutes of new material in a week. It got to the point where I was trying to homeschool them, and I would present new material. I would try it a couple of different ways. If it worked, fine. If it didn't work, I would just set it aside, go back in a couple of weeks, and in a lot of cases, it had filtered through. But that's 20 minutes of new material in a week. It takes an awfully long time to get an education that way. Just shows the range of severity cognitively, physically, etc. This was after diagnosis. This was with the help and support of a very supportive ME specialist. This was the best we could do.
Thank you so much for sharing, Denise. What haven't we covered that you might like to share with our audience today?
I would just like to say, so even once I got diagnosed, a challenge for me as a teenager was when other kids look at you like you're strange because they don't quite understand what's going on with you, then people who maybe previously would have been a friend or friendly tend to pull back. But I think it is something that I certainly didn't want to express that I found hurtful. I think it's something to be aware of, that kids are probably going to struggle with, especially if they're undiagnosed or the illness they have isn't, isn't being recognized and respected by the adults around them.
As doctors, I think it's really important to support the family because you're a partner with the parent in this. And even when you've got the diagnosis, it's still all symptomatic. So they're going to be seeing other specialists in addition to you. It's not easy in our medical system to set aside time to consult with other doctors. Lauren has 7 different doctors. They all want to help her and they're all focused on one aspect of her illness. So that means the family's in the position of being the interpreter of the specialist to all the other doctors that they're seeing. This is really, really hard. The impact on the family of having someone who's severely ill, on the family, on your career, on your finances, it's a whole boatload of stress. Anything you can do to support those families, I think would be super, super helpful.
Be the pioneer. Be the one who starts to do this sort of thing in your practice. Encourage your colleagues to do the same.
The one last thing I want to say is thank you. Thank you
Yeah.
for coming. Thank you for listening to us. Thank you for being here.
Thank you for being willing to learn.
Thanks to everybody for participating in our panel. A reminder to anyone in the audience, if you have experience either as a caregiver or as a child with ME, we will be holding panels with people with lived experience throughout this series. So be sure to get in touch with us if you would like to participate.
Thank you to Dr. Rowe, and thanks again for viewing Evidence-Based Pediatric ME CFS. Please bookmark and share with your colleagues. Our next presentation will be available at the exact same youtube.com address. Please email your questions for Dr. Rowe or for any of our lived experience panelists at meactmaryland@gmail.com. Our next presentation is August 12th at 1 p.m. That's a Monday. It's on orthostatic intolerance. We'll see you then.